Thanks, Anna. Thank you. Good morning. Thank you so much for waking up so early to join us for this particular session.
Is
So,
the mic? Is
can
it
you hear
on?
me? Yep, okay, great. So I thought I will show you where I work. Over here is a landscape view of the hospital. To your left, if you can see where my mouse is where the hospital is. Singapore is very small, unlike India or Calcutta, so we have we don't have a lot of land. So a lot of our offices and hospitals are built very tall. So that's where the hospital is, and that's where the university is to the right. So it's all within walking distances, and this is one of the tertiary institutions in Singapore. Today, I'll be speaking a little bit more about angle closure glaucoma, something that is a bit more common in Asia and amongst Chinese as well. These are my disclosure, a couple of invention disclosures and patents that's relevant to the content of today's talk. And this is the scope that I will go through and have some patience with me as I go through what angle closure is and how we intend to diagnose this through imaging, as well as how we manage them using evidence-based medicine. So what is the spectrum of angle closure disease? And throughout the content of today's talk, I'll be referring to this spectrum of angle closure disease and how we diagnose them, as well as how we treat them based on how severe the condition is. Firstly, you will have the asymptomatic patients who have narrow angles. We call this occludable angles. In other words, the synechia hasn't formed, pressures are normal, and the optic nerve function is normal. This could sometimes be a first world problem because we detect them way too early, and now they have to be on follow-up in the eye clinics. If you don't do anything about this, a small proportion of these patients progress to what we call primary angle closure. This is where there is evidence of synechia closure at the angles. The pressure is starting to creep up. Sometimes you don't get the pressure creeping up, but you get peripheral anterior synechia. But once this is established, the condition becomes primary angle closure. The nerve, if you will notice, is still not damaged. There's no structural or functional deficit in these patients. This is a small subset and subgroup of patients, and if you catch them now, while they are still asymptomatic and with no functional deficit, the outcome can still be very, very good. Now, the problem is that you don't catch them at the first and second phase, and they progress. As the pressure start to come up and they start to exert pressure onto the optic nerve, and the optic nerve start to crumble, have structural and functional deficit, you enter what is called primary angle closure glaucoma, or in the sometimes you hear this term called chronic angle closure glaucoma. These are people where the pressure is starting to be elevated, and now they have both structural and functional deficit on the optic nerve. So throughout the course of today's talk, I'll be referring to PACS, PAC, and PACG. How do we treat each and every one of this severity of primary angle closure disease? So let's maybe go into investigations and what can we do to diagnose this condition. We know how notorious it is to detect angle closure. It is not so simple. The Van Herrick rule or the Van Herrick screening tool is still very good. If you could use a slit and cast it to the angle, cast it to the close to the limbus of the angle, you'll be able to detect angle closure. But the gold standard, and it is still the gold standard, is gonioscopy. Gonioscopy, however, is subjective, requires practice, and it can be variable. So different people can see different things through gonioscopy. Can perform photogonioscopy, like in this particular tool that we developed, that can be used by the clinician to detect dynamic changes in the angle through indentation gonioscopy. But my favorite tool so far has been the anterior segment OCT, and I'll show you why this is particularly useful and gives you a good cross section as well as the mechanism of angle closure that I use now to guide my management of angle closure. What is the advantages of anterior segment OCT? I think I won't put too much emphasis on this. We all know that it is easy to use, they are non-contact, it's rapid, it is objective, but it is a little bit more expensive. You can't visualize the ciliary body. This ciliary body is hiding behind the iris, and it plays a big part, and we know more and more now that the ciliary body position, the size of the ciliary body, plays a big part in angle closure. It is not dynamic, you can't indent, you can't differentiate it, at least in theory, can't differentiate between appositional or synechial angle closure. The ultrasound biomicroscopy is something that you might have in your practice. It is particularly useful in visualizing structures behind the iris, such as the ciliary body, as well as the zonules and the suprachoroidal structures. But it is something that requires a skillful operator. You need some time to perform the ultrasound scan, and there's contact required from this patient. In my center, the patient does this in a supine position, so that is yet another disadvantage of the ultrasound biomicroscopy. As I mentioned earlier on, what are the indications of ASOCT? You have the clear and the distinct advantage of using anterior segment OCT in my practice is to determine the mechanism of angle closure. And we all know that there are several mechanisms of angle closure nowadays, and you can use targeted treatment to address this. We can also look at the assessment of laser procedures. You monitor these chronic conditions over time, and you can also assess the position and the patency of glaucoma tube shunts and evaluate the anterior chamber, especially if there is corneal opacity. Let's take a look at these older scans. These are time domain OCT scans. You can't find them anymore. I don't think Zeiss produced the Visante anymore, but these are time domain OCT. You can see that we have now moved on and used swab source OCT that gives you, number one, clearer resolution. You can see all the way down to where the Schlemm's canal is for some of these scans. You can also get quick 360-degree scans of the anterior segment structure rather than just one cross-sectional scan that the time domain OCT gives. So that gives you a lot more data, gives you a lot, gives you more data points to detect and monitor these patients with angle closure. Shall we speak a little bit more about the mechanism of angle closure, which I think makes sense, it's logical to me. We all know that pupil block mechanism is one of the key mechanism of angle closure. It is now increasingly shown that there are multiple other mechanisms of angle closure that you should be looking out for in your practice. If you draw a line from the sclera spur, and you can see that from the red line to the end of that pupil, you can see there is prominent bowing, right? This is what we call iris bowing, and that's because there is a differential pressure gradient between the posterior chamber and the anterior chamber. This is classic. And when you see this, like when you see a pupil block like this, peripheral anterior, laser iridotomy helps to elevate this mechanism. But there are other mechanisms where the iris profile is a lot flatter. You can see over here in B and C, and these are typically plateau iris or thick peripheral iris, and these are mechanisms where maybe the iridotomy may not address these mechanisms, and I will show you examples how just by doing laser iridotomy for all of these patients with primary angle closure does not address and eliminate the mechanism of angle closure. And lastly, we are getting more and more data on the role of the lens in angle closure. You can see over here that the lens vault is very high, and that's the main mechanism of angle closure in these patients. And removal of the lens may not be a bad idea to try to reduce the risk of progression in primary angle closure. And how about multiple mechanisms? Yes, of course you can get that. You can see this particular patient with both pupil block and increased lens vault, right? So there's both mechanism over here involved. Both laser iridotomy and lens extraction will help this patient open up the angle and reduce the risk of progression. So this is multiple mechanisms. You can see the clear-cut example of how just by doing laser iridotomy without addressing and identifying the mechanism can make a big difference. Over here towards your left, if you look at panel A, you can see a patient with pupil block mechanism, and after a laser iridotomy in panel B, the angles open up. Because you elevate, you remove that pressure gradient, you flatten the iris profile, the angles open up. This is a successful laser iridotomy. I define success by opening up of the angles. But if you see to your right, another example of a patient without pupil block, right? Prior to laser iridotomy, the angles are closed. Guess what? After laser iridotomy, the angles remain closed, right? So there is residual angle closure. It just tells you that there are other mechanisms of angle closure that needs to be addressed in these patients. So by doing laser iridotomy alone may not be, I think in my center, when I train my fellows and my residents, I tell them after laser iridotomy, you can't quite discharge the patient. You need to monitor the patient, you need to follow up the patient and look and assess the outcome of your laser iridotomy. So allow me to introduce you to this mechanistic way of addressing the angle closure condition that the patient presents to you with. You can have primary angle closure to your left or secondary angle closure. If you can determine the mechanism, you can then have a more targeted treatment to that particular patient and help to improve and reduce the risk of them progressing through PACS to PAC to eventually PACG. Anterior segment OCT is there for a long time. It's nothing new. You have seen these complex images, I'm sure, right, through journals and even in presentations as well. These are probably not very friendly. You can hardly determine which parameters that you want to track or which one is the one that's more important. Can we make it more user-friendly? Can we make it more friendly to our practice? The answer is probably yes, right? In this particular situation, in the past, when you want to detect or measure certain parameters on anterior segment OCT, you have to manually detect where the sclerospur is. So that's problem number one. Can you detect the sclerospur accurately? Number two, is there variability, right? The same patient following you, seeing you over multiple visits, maybe over several years, may have different sclerospur positions, right? The person who is identifying the sclerospur may not identify it at the same place all the time. In this particular paper, we showed that it is possible to detect the sclerospur automatically through the use of AI, segment the images to cornea, anterior chamber, as well as iris, and then make the measurements in automatic manner. And what we hope to do is to come up with what we call a goniogram, right? So this goniogram allows you to detect and see where those angle closure positions are. Is it always in the vertical meridian? Is it always in the horizontal meridian? And once you diagnose the condition, you institute a treatment, you repeat this particular algorithm, you can see whether there is any improvement quickly in your anterior segment OCT scan. So we can reduce the number of gonioscopy that you do through the use of anterior segment OCT. How about predicting the outcome of laser iridotomy in these patients with primary angle closure suspect? Just using anterior segment OCT, we have also shown in this particular paper that what is the most distinguishing feature, what are the determinants of success of angle closure is down to three things. One is the angle recess, two is the iris curvature, and the concavity ratio. No surprise. I think I mentioned this earlier in my talk, that the iris profile or the iris bombay that determines pupil block is the mechanism that is being addressed by laser iridotomy. So if you look at the anterior segment OCT and you see this bowing of the iris, then you can be quite sure your laser iridotomy will help to address the angle closure. Let's go to this, back to this spectrum of disease of angle closure again. To treat or not to treat, right, in patients with primary angle closure suspect. Remembering they have no symptoms, they have no disease, they come here and sometimes you detect them through your investigations. The ZEP study has helped us shed some light on this for patients with PACS. So let me repeat that. These are only for patients with PACS, meaning no pressure rise, no anterior synechiae, and this particular study has shown that, for the interest of time, I wouldn't go through the details of this particular study, but in essence, the study, which is a 14-year follow-up data, shows that laser iridotomy does reduce the incidence of progression, right? Progression to what? Progression to PAC, meaning pressure rise or acute angle closure attack. But the number to treat, to reduce that is high. To reduce and prevent pressure rise, you need to treat 444, and to prevent acute angle closure, you need to treat more than 200 eyes. From the epidemiology point of view, from the purpose of a public healthcare setting, doing laser iridotomy indiscriminately without looking at the mechanisms is something that the paper suggests you not to do, right? But then I think I've mentioned just now, look at the mechanisms of the angle closure. So that's what the paper showed. Personally, when do I do LPI in patients with primary angle closure suspect? I do consider these factors. Firstly, if the fellow eye has acute angle closure attack, I do laser iridotomy. If this patient has frequent or require frequent dilated fundus exam, they have symptoms related to intermittent angle closure, they are living in an area where they cannot get access to healthcare, and once again, emphasize looking at the mechanism of angle closure. If this particular patient presents with PACS and has thick peripheral iris or has a lens vault, then I tend not to do a laser iridotomy. I won't touch too much on this in the interest of time. I think laser iridotomy is something that's being performed quite commonly in our practice. I'll just show a quick video of how this laser iridotomy is being performed at my center. We do sequential argon and YAG laser, 2-stage. And you can see over here we use a contact lens to try to stabilize the eye. And the first part of the procedure requires the use of the argon. The purpose of the argon is a form of coagulation. Through the use of coagulation, you can reduce the risk of bleeding. You can see that we sight the laser quite peripherally. You either do it at 12 o'clock, close to 12 o'clock at 1 or 2 o'clock. I don't do it at 3 or 9. I know some people do that. And the purpose of the laser is to thin out the iris. And you can see over here that the iris is now starting to thin out. And you can see that the hardly any bleeding with this. Otherwise, if you just use the YAG laser, the risk of bleeding is rather high. I'll move on from here, and I'll touch a little bit more on the PAC as well, right? And how do we manage patients with PAC? And now I think because Bo is not here, so I have more time. Am I right? Got it. You can see that as I progress, I speak faster and faster and faster. Okay, so the EAGLE study has helped us and guide us in how to treat patients with PAC. Now, in essence, patients with PAC, meaning high pressure, PAS is present, but no glaucoma damage. My practice has changed through the EAGLE study, and even actually before that, our thinking is that removing the lens by experienced hands is a bit better compared to just performing laser iridotomy. And lastly, if a patient has established primary angle closure glaucoma, what do we do then? I look at two big factors. One is the severity of the glaucoma and the target pressure, as well as the medication burden and the tolerance to pressure. So looking at severity, if this patient presents with mild or moderate glaucoma with higher tolerated target intraocular pressure, you can perform either just phacoemulsification alone or with gonio's enucleolysis, and some people have mentioned that goniotomy is also particularly helpful in this case. If there is big and huge medication burden, then cataract surgery with glaucoma operation is my target. It's my first choice of surgery. Needless to say, if the glaucoma severity is high, that means they have severe glaucoma and a target pressure that a low target pressure is required, then combined cataract and glaucoma operation is my go-to procedure. I would like to share this particular article from a close collaborator of mine in Guangzhou, who looked at comparing phacogoniotomy versus phacotrabeculectomy, and I repeat, in eyes with advanced PACG. These are patients that require low pressure after surgery, and they showed that there is the phacotrabeculectomy group is not inferior to phacogoniotomy group. In fact, they show that there is less post-op complication in the phacogoniotomy group and less intervention after surgery. Something to consider, something to think about. In short, in conclusion, in patients with PACS, the options include conservative. I'm beginning to do more and more of this. You can do laser PI if people block is the main mechanism, or you can consider early cataract extraction if the patient has cataract. If the patient has PAC, it's either laser PI or cataract surgery. My practice has shifted towards more of cataract surgery in this group of patients. And lastly, with primary angle closure glaucoma, you might and you may have no choice but to perform glaucoma surgery in these patients. With that, I thank you for your attention. I'm open to any questions. Thank you.